What could be more primordial to the endocrine section than diabetes? There are 10,000 new diabetics per week, yet we seemingly tolerate the failure to have this disorder cured in our culture. If we statistically asked all of you who are taking this class, how many of you have a diabetic family member or you yourselves are diabetic, the answer is 75%. Diabetes is defined as having two persistent fasting blood glucoses above 125, so above 125 on two separate occasions. Now, type 1 diabetes, its onset is in childhood, and childhood can go on to 12, 13, 14, 16, so it doesn't have to be that you're a baby when you have it. And you're insulin dependent from an early age because you basically kill off your pancreas. It's an autoimmune disorder. It's not related to obesity, it is an insulin deficiency, straight up ahead, burnt out pancreas. Type 2 diabetes is adult onset in nature, generally speaking, but childhood obesity is so much greater that fundamentally you could have it in a 14-year-old now if they're very obese. It's directly related to obesity and insulin resistance because the only two tissues in the body that must have insulin is a adipose tissue and a resting muscle. So therefore, if your pancreas is only just able to support a 110-pound body and you're 225 pounds, you're going to be diabetic. Ultimately, when symptomatic, however, the presentation of polyuria, urinating a lot, polyphagia, eating a lot, polydipsia, drinking a lot, hasn't changed. I see one every week in the hospital. And type 1 diabetics are thinner than type 2 diabetics simply because type 2 diabetics are brought on by obesity. Now, the type 2 diabetic is more resistant to DKA because DKA occurs when you have simply you just don't have enough insulin. So, since type 2 diabetics tend to preserve at least some insulin function, the type 2 diabetic is more resistant to DKA. In other words, they may not be normal, but they have just enough insulin to keep themselves out of DKA. Both types have decreased wound healing. Both types are immunocompromised. Both types have white cells that just don't like to get up and go to work in the morning. Answering the what is the best initial and most accurate diagnostic test questions, we have, in addition to two fasting glucose measurements above 125, one glucose level above 200 with symptoms such as polyuria, polydipsia, polyphagia is enough. I don't have to do a whole bunch more if I got one that's symptomatic. The oral glucose tolerance test is the most sensitive test of diabetes, most sensitive, and the most technically difficult to do because you've got to do many blood glucose measurements after making the patient drink this nasty, super sweet syrup. When is this the answer? Well, oral glucose tolerance test is most frequently the answer when you got to know right away. And when do you have to know right away? Pregnant ladies got to know right away. You got to know before the baby becomes anatomically abnormal with their head size. Hemoglobin A1C has become much more common as a diagnostic test because you only have to do one, and if your average glucose that's attached to your red cells, glycosylated hemoglobin, it's like a Krispy Kreme sugar donut, glazed donut above 6.5, one is good enough. The best initial therapy for type 2 diabetics is diet, exercise, and weight loss. Remember, this is only for type 2 diabetic because you can't tell a thin type 1 diabetic that they're going to diet their way out of no insulin. But a person who's a type 2 diabetic, wow, well, weight loss and exercise will control as much as 25% of cases. We'll never need medications. It's amazing that you can do that. You can basically eradicate a quarter of disease because exercising muscle doesn't need insulin. And not only does exercising muscle not need insulin, if you go exercise for 15 to 20 minutes, that effect on sucking up glucose by your muscles will be in place for 24 hours. It will continue to pull glucose out of the bloodstream just by the effect of that one short period of exercise. The question will describe a person with recently diagnosed type 2 diabetes who's tried 3 to 6 months of lifestyle modifications to correct their weight, to exercise, to decrease the total caloric intake in their diet, and it just hasn't worked. What is the best initial drug therapy? And that question is undoubtedly answered by metformin. Metformin blocks gluconeogenesis and therefore doesn't cause hypoglycemia and also doesn't cause weight gain. Sulfonylureas increase insulin release from the pancreas. Insulin causes you to gain weight because insulin makes fat cells, adipose cells, pick up glucose, pick up lipids, and put them into storage, so it actually can worsen the weight gain. Dipeptidyl peptidase inhibitors. Wow, that is a mouthful. Dipeptidyl peptidase inhibitors. Ooh. Well, whatever these unpronounceable things are for you, they increase insulin and decrease glucagon. Sitagliptin, saxagliptin, linagliptin are drugs that inhibit the metabolism of something that comes out of your body routinely every time you eat. Out of K and L cells in your body, out of the L cells in the ileum and the K cells in the duodenum, are the incretins. And the function of incretins is for a minute or two to bump up insulin from the pancreas and to decrease down glucagon from the pancreas. And that is to help you metabolize your food. But the problem is they have a very short half-life. So we want to extend them. Everybody's got incretins. Those incretins are sometimes called glucose insulinotropic peptide. Oh my goodness, it's so long. GIP, how's that? Okay, I can take that. And glucagon-like peptide. And those substances come out of your intestines every time you eat. And they help you metabolize the food by raising insulin and decreasing glucagon. So how do we take advantage of that physiology? By giving these drugs, sitagliptin, saxagliptin, linagliptin, to extend their half-life, to help you raise insulin and decrease glucagon out of your own pancreas. And the reason decreasing glucagon is so critical is because glucagon raises glucose levels. So we get rid of the glucagon, brings the glucose levels down.
The thiazolidinediones, or glitazones, are rosiglitazone and pioglitazone. Now, these drugs have been used much less in the last couple of years because of concerns about congestive heart failure. They are still on the market, they are still very effective medications, and they work by increasing peripheral sensitivity to insulin. Unfortunately, they can also increase fluid overload. They are added on to metformin or to a sulfonylurea to help keep people off of insulin. Nateglinide and repaglinide are two medications that are insulin secretagogues, meaning they basically work like a sulfonylurea. They increase the release of insulin from that pancreas. And like sulfonylureas, they can also predispose to weight gain because these drugs squeeze some extra insulin out of that pancreas. The insulin makes the fat cells pick up lipids, and glucose is converted to lipids and can increase the weight. But they're not ever synergistic with sulfonylureas. They are an alternative to sulfonylureas.
Diabetes management is expanded. So we have now these drugs, the incretins, exenatide and liraglutide, which simply raise insulin, decrease glucagon levels, and decrease gastric motility, and help in weight loss because they decrease gastric motility. Matter of fact, they're fabulous weight loss drugs. They have to be given by subcutaneous injection, so in that sense, they have the same difficulties as insulin. They're not a pill. See, the first classes that we describe now are all pills, but incretins is the group name for GIP, glucose insulinotropic peptide. In other words, food goes into your tummy tum. It stimulates your duodenum and your ileum to make a hormone that releases insulin. And this is simply these drugs, exenatide, liraglutide, are an artificial version of that. That instead of lasting 1 to 2 minutes makes it last 1 to 2 days. And that's a really cool thing because they also make you lose about 10 to 20 pounds. Now, these next set of drugs, the alpha-glucosidase inhibitors, acarbazimiglatol, these are not here at the end randomly. They are here after metformin, after sulfonylureas, after glitazones, after DPP4 inhibitors, which are the four oral classes that are unique and usable, even after niteclonide and repaglinide, because alpha glucosidase inhibitors did not take off too well for a very good reason. They block glucose absorption in the bowel. Any of you lactose intolerant out there? Well, if you're not, take this drug and you'll know exactly what it feels like to be lactose intolerant. It causes flatus, diarrhea, and abdominal pain. Isn't that what lactose intolerance does? Well, what is lactose intolerance? It's a person who can't absorb lactose, so the lactose goes down into their colon, and the bacteria in their colon go, yippee, lunch is here. And they overproduce and they make gas and abdominal pain and diarrhea. And that's why these drugs have never taken off, because you have to take them 3 times a day. You have to take them as you eat. And it definitely blocks glucose absorption, But the problem is that it's a lot of side effects for not a huge clinical benefit. Another set of drugs that did not take off so well, but I'm compelled to tell it to you for the high-functioning gunner student. Want to get every question right. Pramlintide is an analog of a protein called amylin, secreted normally with insulin. And amylin decreases gastric emptying and decreases glucagon levels and decreases appetite. Sounds fantastic, right? Hasn't been used too much, but nevertheless, that's what the drug does. It's pretty cool. Remember that doing this course is a way of filling in gaps and holes in people's medical education. It's a way of smoothing out the little bumps. So if there are drugs like some of the ones that you just heard about that you haven't heard of, it's okay, because this is a complete operation here. This is making sure that you're not going to have any surprises on your test day at all. But I will tell you that if you're on your clinical rotations right now, and you know all those drugs that we just described, you will know more than your junior residents. Insulin is what we use as an inpatient, but outpatient, ambulatory, which is where 99% of the diabetics are, insulin is added if the patient is in control with oral hypoglycemics. Now, it's not entirely clear whether we should go to insulin after 2 oral drugs, 3, or even 4 after a person is on metformin, then you add a sulfonylurea or add the glitazone or add the DPP4 inhibitors. It's not clear whether it should be after 3 or 4 of those oral hypoglycemics. And not clear means you are not asked. It will have to be a clear statement. It'll have to clearly say the person's on a bunch of oral hypoglycemics and they're just not being taken care of. And you add it, and insulin glargine gives a steady state of insulin for the entire day. And that's because this has a very interesting kinetics where basically it goes all the way up to its fully therapeutic level and then stays that way all day long. Now, you don't have to learn dosing for any of them, and glargine is much more steady than NPH. NPH goes up, it goes down, it goes up, it goes down. It's harder to manage. You combine these long-acting insulins with short-acting, Lispro, Aspart, or glulisine. Lispro, Aspart, and glulisine are the drugs that you use in injection just before meals. Just with meals. Because they last a tiny time. They have an effect in 5 and 10 minutes, and poof, gone away in 2 hours.
This rather daunting looking algorithm shows that when you have a decreased amount of insulin, you have a decreased uptake of glucose by the tissues. And this leads to increased breakdown of proteins. Proteins tend to break down without insulin. Now, because you have an increased breakdown of proteins, there's also an increased synthesis of glucose because the broken down proteins can be used for gluconeogenesis. In the same way, insulin forms glycogen. You break down glycogen without the insulin. One of the things that's greatly underestimated is the amount of extra glucagon that goes up in a diabetic. This is why you have breakdown of glycogen. This is why you get an increased synthesis of glucose, which is inappropriate, and why you get an increased liver output of glucose, all inappropriate. It's understandable why you get a decreased uptake of glucose by the tissues when you don't have insulin, but did you know that the liver actually is making extra new sugar? Ooh, that's bad. Hyperglycemia. On the right side of the table, we have an increased breakdown of fats because insulin is a hormone of storage. And when you don't have insulin, fats break down, triglycerides break down. And as we go down the The row on the right, this leads to an increased free fatty acids in plasma, and the free fatty acids are broken down to make more ketones, and hence the fundamental feature of ketoacidosis.
Taking a second to review the insulin half-lives, aspart, glulisine, and lispro, and all of these are just basically manipulations of amino acids on the basic insulin structure so that it will change the half-life. These have a peak onset in 5 or 10 minutes, 30 minutes. They are working right away. They start to work instantly, just like eating a meal. And these are exclusively with meals. Regular insulin has been used this way for a long time, but it doesn't take up onset quite as fast as the aspart, glulisine, and lispro. If those are all listed the same, by the way, you cannot be asked to choose between them. The other four, NPH, ultralente, lente, and glargine, are all the long-acting insulins so that you are using these in combination with the shorts. So that's why a person who's diabetic and insulin using diabetic, an insulin dependent diabetic, whether they're type 1 or type 2, has to routinely combine two different types of insulin. So that's expected, that you are combining a long and a short acting insulin, a long all day long and a short just before meals.
Diabetic ketoacidosis, or DKA, is simply more common with type 1 diabetes. This is because you just don't have enough insulin to keep you out of DKA. It can definitely present with type 2 diabetes. It's much less common because type 2 diabetics may not be normal, but they have enough insulin to most often keep them out of the most dire straits of DKA. DKA presents with hyperventilation from direct stimulation of the brainstem by acid, altered mental status from the hyperosmolar syndrome, metabolic acidosis created by the fact that keto acids directly make metabolic acidosis. And because you're inserting a new anion, it increases the anion gap because both the chloride and the serum bicarbonate go down. As a matter of fact, when you're evaluating a case of DKA, the number one thing that you use to tell how severe is it is what's the anion gap, how low is the bicarbonate. Hyperkalemia is common, and that's because the acidosis shifts potassium out of cells, and it's because without insulin, potassium builds up outside the cells. Remember, insulin, just in the same way it's a therapy for hyperkalemia, without insulin, potassium builds up outside the cells. Insulin drives potassium into cells with glucose. Insulin stimulates the sodium-potassium ATPase, which drives potassium into cells more. Now, in order to protect the body from itself dying from hyperkalemia, when it goes to the kidney, there's increased urinary spillage of potassium into the urine. So there's a hyperkalemia in blood, but decreased total body potassium because of urinary spillage. An increased anion gap on blood testing, and a serum is positive for ketones. Just remember, you can't rely on ketone levels to tell you the severity of the disease.
The treatment for DKA hasn't changed in 90 years. Large volume saline and insulin replacement. When the potassium level starts to come down, even when it comes down to normal, replace the potassium when potassium level approaches normal because the total body is depleted of potassium, and correct the underlying cause. You see, besides making sure people take their medications, infections cause DKA because infections cause catecholamine release, glucagon, growth hormone release, cortisol release, and it inhibits insulin. And correct any serious illness that caused the DKA. Bottom line on DKA, lots of fluids and insulin, replace that potassium when it starts to come down, and do a lot of blood testing. A 57-year-old man is admitted to the ICU with altered mental status, hyperventilation, really high sugar. Which of the following is the most accurate measure of the severity of his condition? Which of these measures severity the most? Bicarbonate. Bicarbonate. If it's low, you're going to die. When is it time to come out of the ICU? When the bicarb comes up. Glucose level is not as accurate. You can have a glucose level of 200, but if your bicarbonate's really low, you are in big trouble. You could have a glucose level of 700, but if your bicarbonate level is normal, it's not so bad. Urine ketones are useless, means very little. Blood ketones mean much more, but the problem is not all blood ketones are detected by the test. And the pH level on a blood gas is good, but you need to know what's responsible for that pH. What that means is that if you have a pH that's 7.35, you might go, hey, that's pretty good. That's pretty normal. But what if the person's hyperventilating, going, and the minute they slow down in their hyperventilation, their pH drops down to 7.2. So it's not enough just to know what the pH is. You also got to know, is there a respiratory alkalosis that got it there? That's why serum bicarbonate is the single most accurate method of knowing where's your DKA at. Has it resolved? Glucose could be up, but if that bicarb has gotten normal, you're okay. You cannot overemphasize how important the health maintenance section is on diabetes. It is incredibly highly tested. Every diabetic should receive a pneumococcal vaccine. Every diabetic needs a flu vaccine every year. Every diabetic needs a yearly eye exam to see if there's proliferative retinopathy, which needs laser photocoagulation. Proliferative retinopathy means neovascularization or vitreous hemorrhages. Neovascularization, vitreous hemorrhages. Yeah, can't wait until they lose vision. That's like asking someone, hey, are you depressed? No, let's wait and see if you're jumping out the window. That's way too late. You got to know before. You got to get those LDL under 100, because remember that diabetes is a coronary artery disease equivalent. So the target has to be at least under 100. ACE and ARBs, remember that we have a unique target of blood pressure for the diabetic, which is to get them under 130/80. And so if the question says the person's gone on a blood pressure medication and their blood pressure is now 135/85, if this was the general population, the answer would be stop there, it's good enough. But not in the diabetic. Increase that dose and get them under 130/80. Or microalbuminuria, ACE or ARBs. Now, ACE inhibitors are always first. ARBs are as an alternative. And remember, microalbuminuria is albumin level that is too low to be found on a dipstick. That's below trace. That's less than trace. And a foot exam for neuropathy and ulcers. Because if you think about it, how often do you really look at the bottom of your feet? Well, you don't. You don't really look at the bottom. You say, well, I would feel it if there was something there. Well, you would feel it, but they don't. And they walk around and they don't feel it, and then all of a sudden they got a big ulcer that's going to end up causing a bone infection. Now, a long-term complication of diabetes is gastroparesis or gastroparesis. This basically means your stomach doesn't feel the stretch of the food. The number one stimulant for gastric motility is stretch. It's distension. But it's based on being able to sense it. If you can't sense the stretch or the distension, then you won't be able to move your food forward. And that's why you get immobility of the bowels in diabetics. Not diabetics for a few years, but diabetics for a long time. Bloating and constipation, early satiety and vomiting, all based on the fact that you can't feel the stretch in your stomach. Diabetics need a foot exam. They need a foot exam because they can't sense the stretch on the foot. So you get a foot exam because they can't see it. That same inability to detect sensory stimulation that occurs in the foot is happening in the bowels. So they can't sense the stretch. The food goes in and just lays there. It gives them abdominal discomfort. Now, you treat it with metoclopramide and erythromycin. Metoclopramide is a gastric motility agent. That's part of its job. That's part of why it helps with diabetes in gastroparesis, because it simply helps contract the bowels and make them go forward. Erythromycin, weirdly enough, we're taking advantage of what's an adverse effect of erythromycin. So the adverse effects of erythromycin are gastrointestinal hypermotility. Well, erythromycin hypermotility is bad in the normal parts. What's good when you have diabetic gastroparesis? Because it increases motilin. It makes that bowel move forward. Now, some of you might say, isn't it a problem to be on erythromycin, an antibiotic, all the time? And the answer is actually no. It's not a problem. One, you're using a very tiny dose. Number two, erythromycin is a drug we just don't use too much as an antibiotic anyway because there's already a lot of resistance to it, so it's not a first choice. We use azithromycin and clarithromycin. The third thing is that we don't use erythromycin too much because of the GI adverse effects of nausea, vomiting, and diarrhea. So it's like Goldilocks in the three bowels. Normally in diabetes, ooh, this bowel is too slow. Erythromycin in a normal person, ooh, this bowel is too fast. But when you use erythromycin in a diabetic, this bowel is just right. There is no way to know what's going on inside the eye of the diabetic without looking inside it with a dilated ophthalmologic exam. You can't tell who's got proliferative retinopathy versus non-proliferative. For non-proliferative retinopathy, we just don't have anything to really control it early. Just tighten the control of glucose, and aspirin just doesn't help. Aspirin helps with all other vascular disease, but not with retinopathy. That's because retinopathy has a completely different basis. It's not platelet accumulation. It's increased growth factors. The blood vessels are just growing over the retina, and you won't be able to see things. Proliferative retinopathy is neovascularization, vitreous hemorrhage. You can only tell when you look inside and you laser it. Proliferative retinopathy with that neovascularization, you can also stop the blood vessels being grown with medications called VEGF, or vascular endothelial growth factor inhibitors, VEGF inhibitors, bevacizumab and ranibizumab, the same as we would use for macular degeneration, can also be used. The laser basically stops the proliferation of those blood vessels by zapping out the peripheral retina. Peripheral neuropathy happens because the blood vessels that are around those small nerves get impaired, and it gives decreased sensation in the feet in a glove and stocking fashion, mostly in the feet. Sometimes it can cause hand problems, but it's mostly in the feet. It's the main cause of skin ulcers. You can't feel the little wear and tear. It can lead to osteomyelitis because the skin ulcers lead to the skin breakdown, which gets infected, then spreads into the bone. The pain syndrome is treated with the medications for neuropathic pain, pregabalin, gabapentin, tricyclics. There's no clear difference between them. So as we finish the diabetes section, I want to be 100% clear. If you go into test day without knowing the health maintenance of a diabetic, you are going to lose 3 or 4 points. And it's very straightforward. Here's your list. Blood pressure under 130/80, ACE or ARB. LDL under 100, use a statin. Pneumococcal vaccine and influenza vaccine for everybody. Look at that urine for microalbuminuria, which means less than what you'd find in trace, and use an ACE or an ARB, which delays the progression of the renal insufficiency. That's the health maintenance.